Good afternoon. My name is Shawnly. I am a master's student here at UC San Diego. And today I will be discussing the exploration of tobacco, nicotine dependence, substance abuse, and other risk factors in cancer mortality. I am conducting this research under Dr. Kumo. A little short agenda for today. I'll be discussing the background, coherence and experiment, methods, my research question, stage imputation, results, conclusion, and implications of findings. First off, cancer is the second most leading cause of death here in the United States, according to the CDC. Cancer itself often causes pain, and all depends on the type of cancer, the stage, and tolerance of the pain that the patient has. Cancer treatments are also painful, tumors pressing on the organs, nerves, or bones. Thus, physicians will prescribe opioids to help cope the patient with pain. For that reason, one of the risk factors I'll be looking at is opioids. The second risk factor I'll be looking at is alcohol use. The National Cancer Institute reported that cancer patients that consume alcohol while receiving treatment make their treatment less effective. In addition, drinking alcohol can also lead to an oxidative stress in cells, causing them to create more reactive oxygen species. This can lead to damage in the cells that might increase the risk of cancer. My third risk factor that I'll be looking at is amphetamine. Legally, it is prescribed to treat ADHD, obesity, and narcolepsy. Illegally, however, it is used to get high or enhance your performance, used by athletes. So when you combine amphetamine and alcohol together, this might cause one to feel less intoxicated due to the stimulant effects that amphetamine has, leading to drinking more. Thus, this increases risk of cancer, and if you are doing this while as a receiving treatment for cancer patients, this increases your risk of cancer mortality. My fourth risk factor here is cannabis. So the CDC reported that the usage of cannabis is used to treat side effects of chemotherapy, such as nausea, vomiting, and neuropathic pain. In fact, they did a study on 21 cancer patients experiencing chronic pain, and they were given a vaporized cannabis and morphine. Interestingly, they found that patients reported a better relief of pain than morphine alone. Last but not least, my fifth risk factor is tobacco. As many of you know, tobacco causes lung, liver, and colon cancer. Cancer patients who smoke have a reduced quality of life and a lower instrumental activity of daily living. In 2023, they did a study on what types of cancers have a lower instrumental activity of daily living and an impaired neuropsychological function. What they found was that breast, colon, and thyroid cancer had the lowest instrumental activity of daily living and an impaired neuropsychological function. For that reason, I am including breast, colon, and thyroid cancer in my study. In addition, I am also looking at lung and liver cancer. So, coherence and experiment. My 5 risk factors that I'm currently doing research on has not been published in research articles. However, the other risk factors that have been published in literature are tobacco, reproductive factors, exogenous hormones, alcohol, and obesity. A similar retrospective study was done, except it focused on substance abuse, tobacco, and mental health on cancer patients. A randomized control trial would not be plausible for this type of study just because it's unethical to assign these risk factors randomly to patients. And a little background of going down the lane of chemistry, alcohol is a carcinogen, and alcohol contains ethanol that is then broken down to acetaldehyde, which damages DNA. So when you have an accumulation of damaged DNA, this can lead to cancer. In addition, consumption of alcohol can raise estrogen levels, which can then increase your risk of breast cancer. Tobacco and cannabis itself are carcinogens, and they contain toxins that are very harmful for the body. Amphetamine, on the other hand, is used as a co-analgesic, meaning it's more as a comfort. It improves quality of life. That's the main purpose of using amphetamine in cancer patients. Opioids, on the other hand, however, a long-term history of opioid to treat chronic pain creates an elevated risk of cancer. In addition, if you are receiving opioids during cancer treatment, this can result in a poor survival outcome. So methodology, I will be doing a retrospective cohort study. I'll be using an electronic data set to grab my sample size. And the data set that where I'm gathering these records from is pretty huge. It has over 1 million patients. And since this is a retrospective study for temporality, I am probing for an association between these risk factors that I've mentioned and death. So I will be specifically looking at cancer patients seen here at UC San Diego from early 2012 to present. These cancers include lung, breast, colon, liver, and thyroid cancer. This will be followed up with a 5-year mortality, and the risk factors I've mentioned are opioids, tobacco, amphetamine, alcohol, and cannabis. So my research question is, among adult cancer patients recorded across the UC health system, is tobacco or nicotine dependence, opioid, amphetamine, alcohol, and cannabis dependence a risk factor for survival? And as I mentioned, I am looking at from UC San Diego, specifically a primary diagnosis of colon, breast, liver, thyroid, and lung cancer. The risk factors currently I have are tobacco, opioids, cannabis, alcohol dependence, and amphetamine. And other variables collected are diagnosis prior to 2019, demographics that include race, ethnicity, and age, and tumor node metastasis stage that I will talk soon about. So here, if we go at the bar graph here on the right, we see that it is more female dominated than male dominated in this study. And here on the right here, we have a box plot of age distribution by race. And if you can, as you can see in the bold black, that the mean age for each race ranges from 62 to 65, which is fairly close to one another. So for stage imputation, first off, tumor node metastasis, that I'm going to be saying TNM for short, is a way that clinicians use to assign severity of cancer. So first we extract data available for tumor node metastasis and the number followed by it. Then we're going to calculate age at diagnosis using their birth. Then we take the 2 biomarkers that I'm looking at in this study, which is cancer antigen 125 and C-reactive protein. Cancer antigen 125 is a molecule expressed by tumors, and CRP, C-reactive protein, is a biomarker for inflammation. We look at those two biomarkers. We look at the relationship and correlation with age, since age is correlated with severity, and age is available in this database. Next, we're generating a beta coefficient, and we use that to impute any missing values for these 2 biomarkers. Then we're going to look at the relationship of these 2 biomarkers and age at diagnosis with the stage T, N, and M. We then use a multivariable model that generates 3 beta coefficients, each for T, N, and M, and a linear equation. We use that linear equation to estimate any missing values for T, N, and M. Lastly, we're going to convert these stages using a rule-based algorithm from TNM to stages 1, 2, 3, 4. And as we can see, we have 381 patients in stage 1, 14,511 in stage 2, 7,052 in stage 3, and 819 in stage 4. So for my data analysis, I performed using SQL and R. I generated a Kaplan-Meier graph and a Cox proportional analysis. And here on the right, I have a little bit of my SQL data. So we got patient ID here at the top, then the death date, and then for case, we're looking at the 5-year mortality case. So for results, I have a sample size of 23,018 patients. For opioid, I have a 98 sample size with a 5-year mortality at 34.7. Tobacco, 811 at 25.6 5-year mortality. Amphetamine at 15 with a 33.3% 5-year mortality. Alcohol at 456 with a 29.8 5-year mortality. Cannabis at 14 with 35.7, and neither at 21,339 with 16.1 5-year mortality. Next, I wanted to look at the overlap of some of these risk factors. I chose alcohol, amphetamine, opioid and alcohol, and tobacco and alcohol because based on previous published literature, these were the top risk factors mentioned. So alcohol and amphetamine had an overlap of 5-year mortality at 54.4%. Opioid and alcohol had a overlap 5-year mortality at 50%. Tobacco and alcohol had a 5-year mortality at 29.7. Now we're looking at our Cox model right here. And we're comparing all risk factors of all patients to patients without risk factors, before and after adjusting for stage. One thing I would like to note is that before and after adjusting for stage, you could see that cannabis was not significantly an increased risk for cancer mortality. However, we can also conclude that before and after adjusting for stage, opiate, tobacco, and alcohol and amphetamine were a significantly increased risk of cancer mortality. Next, we're comparing risk factors to neither, and this is like the meat, I would say, of this paper. So first, we can say that before and after adjusting for stage, amphetamine and cannabis were not a significant increased risk for cancer mortality. However, opioid, tobacco, and alcohol were. But it's important to mention here, before and after adjusting for stage, we see that opioid and alcohol have a higher risk hazard ratio than tobacco. And this might be possibly due to the fact that patients might have a more extreme form of abuse towards opioid and alcohol than compared to tobacco. Next here, we have a Kaplan-Meier graph where we're comparing the survival probability to throughout the years. And we can see that here in the black, we have no dependence, which is representing neither. But here in green, we have opioid with a pretty low survival probability, around like 0.65. Cannabis had the lowest at 0.63, but interestingly, tobacco, I would say right here, had a pretty decent high survival probability. So some limitations in this study, well, the primary for this database is to document patients. However, we use it not for clinical research. A selection bias is that I'm only focusing on UCSD health. This does not apply for globally. And some confounding biases are medical adherence, and I did not account for some confounders that are probably mentioned in published literature, such as obesity, as I've mentioned before. However, I would say the most important confounder that I did mention was disease severity. So conclusion, so after adjusting for stage, there is association for each risk factor that we can see. Opioid and alcohol dependence show a high effect size compared to tobacco, and this might be due to the fact that patients might have a more extreme form of abuse compared to tobacco. Cannabis and amphetamine did not have a significant risk of mortality, and this was possibly due to the fact that they had a low sample size. So implications of study, well, first off, there needs to be more rigorous screening for opioids, tobacco, alcoholism, and cancer patients, or in general, since opioids is very easily prescribed in this country. In addition, amphetamine is rarely studied in cancer patients, so there has to be more increase of study for that. Since specifically, patients that take amphetamine and alcohol, they have an increased risk of a respiratory attack. And what these studies do not imply is that the effects of cannabis as a treatment for cancer-related symptoms or side effects of cancer therapies, meaning after they say they're taking cannabis to treat for chemotherapy to prevent nausea or for chronic pain, what happens after? Also, there needs to be more study on cannabis on lung cancer, and we also don't know the stress factors that the patient might have. This means their diet, their environment. We do not know that. Thank you. Do you have any? That's all. Oh, man.